So I'm here today to talk about surgery in South Africa. Just by way of background, I'm a junior surgical trainee from the United Kingdom. And I went to a hospital called Ungwelazan, which is it's a tertiary trauma centre in KwaZulu-Natal on the east coast of South Africa, about an hour and a half north of Durban. So I'm going to talk to you briefly about a bit about my time there. Okay then, so the things I'll be discussing today are generally a bit about the challenges and the needs. So why aren't there enough doctors in rural parts of South Africa? And why do people find it so difficult to get to hospital? So some of the problems. I'm going to also talk about Africa Health Placements briefly and just mention their role, which is quite pivotal. Sustainable staffing as well. So what are the problems with keeping staff in rural parts of South Africa, and what are some of the solutions that South Africa are employing to try and improve this. Then a little bit about my time there, so just I could talk about that for quite a long time, but we've only got 15 minutes, so I'll quickly move through it. But just to give you a bit of a flavour, there's a lot of senior people in the room, but I'm sure there's some junior trainees as well, who may or may not have considered going somewhere, taking some time out for a year or so. And maybe this will just give you a flavour for a little bit sort of what it's like. A bit about the training you'll receive as well, and how that incorporates into the training when you come back as well, to whether it's the Netherlands, Germany or England. And then just some concluding remarks. So we'll just open up firstly. I'm sure you've all seen this before, and it's gives a nice sort of pictorial view of the distribution of physicians globally. And as you can see, sub-Saharan Africa has particular challenges with regards to this. 25% of the world's health burden is in sub-Saharan Africa, but only 3% of the physicians globally work there. And South Africa is by no means exempt from this as well. So one of the first major challenges is getting to hospital. Patients can find it very difficult to get to hospital in rural parts of South Africa. The infrastructure is particularly poor, and they also have a lot of financial constraints on themselves as well. This is particularly difficult if you're asking people to come back for repeated follow-up clinic appointments. They're often not keen to do this, and this results in delayed presentation, which impacts on the morbidity and mortality of these patients, and evidently affects their prognosis as well. Just a small example, I remember when I'm on call in the evenings there, at about 4 in the morning, busloads of people would arrive. And they'd obviously been travelling all night long, waited for their bus. They get there at 4 in the morning, and they sit there and wait for a clinic appointment at some point during the following day. So it's not just popping around the corner into your local hospital, it's a real event for them getting there. Okay, so there we go. So these pie charts really represent part of the problems. There's a massive discrepancy between the private and the public health sector. So the private health sector, only 8 million people in South Africa use, whereas over 40 million people use the public health sector there. But if you look at the numbers of doctors, 3/4 of the doctors serve just 8 million people in South Africa. 27% of the doctors serve the rest of the population. So there's a massive discrepancy in the doctor-patient ratio. I thought this was quite an interesting slide, just because it shows there's about 8 medical schools in South Africa. And ever since the 1970s to the present day, the absolute numbers of doctors which have been trained through these medical schools hasn't really changed at all, despite obviously the growing health demands there. And I know it's a bit of an old statistic, but in 2003, about 9,000 South African doctors were working in either the United Kingdom, United States, Australia, New Zealand and Canada, which just adds to the problem as well. Okay, so a little bit about the role of AHP. So for anyone interested to move out to South Africa and do a bit of work there, which I'd highly recommend, there's a few major stumbling blocks which can easily be overcome if you work through AHP. And I don't know anybody that didn't go through AHP because it's a very complicated process. The first thing you need to do is get your HPCSA, so to register with the South African Medical Council. which is it's quite a bureaucratic, long-winded thing to do, which involves a lot of complicated paperwork. The second thing is the visa, and that's relatively straightforward, and it's actually relatively inexpensive compared to other countries like Australia, for example, if you want to go and work there. You need to find a job, and the whole process takes about 12 months, and that's worth bearing in mind as well. So AHP were particularly useful. Their help and guidance is essential, and they basically, over the period of a year, just sort of send me bits of paperwork, I fill them in, and send them back. And that process goes on for a little while, and then it's all done. So it's actually not so bad. They can help you find a job as well out there. I've found my own job. You can just send an email out to people, but they locate foreign doctors, but also local doctors as well, residents of South Africa. It's a non-profit organisation, and it's largely donor funded. All right, so sustainable staffing. So some of the issues I feel, which I've noticed, why there are so few people in the public working in the public health sector. And some of the key issues I've identified are that, firstly, lifestyle, and I'm sure this affects everybody in this room. People tend to want to work where their family are nearby, where their friends are nearby, where there's bars, cinemas, local amenities, and also job opportunities as well. So if you're an interventional cardiologist, for example, there's no point, or you'd like to work in a centre where there's primary coronary intervention facilities, and these often occur in the cities, and sometimes people move abroad as well to do this sort of thing. Secondly, work conditions. So work conditions can be quite stressful, and this is mainly because they're quite under-resourced and understaffed in these environments. So you can be working often with a lack of supervision there. And this effect is cumulative. And after people have worked in these sort of environments for a period of time, it can be a bit wearing on them, and people can fancy a change. The other thing is training. Where I was in Nguelazan, there was some formal training, but it was relatively limited, actually. It more occurred on an ad hoc basis. But I have to say, I think the best training I've ever had is intraoperatively at Nguelazan Hospital. The consultants were particularly patient, even in the middle of the night, doing trauma laparotomies. So when it happened, it was very good. Some of the solutions that South Africa have employed. The first one is community service doctors. So when people qualify in South Africa, they do 2 years of internship first. Following this, they have to do a community service year, so all doctors have to do this. And what this involves is basically going to a community hospital or a rural area. So they try and plug the gap, the doctor gap anyway, in these rural hospitals with as just part of the training program. The other thing is a financial incentive, so you get an 18% rural allowance on top of your pay salary, which was very nice. And foreign workforce as well, so people like us, we can go out there and work to try and fill the indiscrepancy between the number of patients and the lack of doctors. So this is where I was working, Nguelazan Hospital, with the helipad just in front of accidents and emergency, and at the back you can't see it is the surgical department and all the theatres. Nguelazan is in KwaZulu-Natal. There's about 550 beds in this hospital and about 8 ICU beds. It serves a population of about 4 million people in a catchment area the size of the United Kingdom, so it covers quite a large area. And there's 22 referral hospitals, so there's plenty of trauma to see. And I'm really talking to you from a point of a surgical trainee. If you want to learn surgery, it's an excellent place to go. This is a slide. This is a photo I took at 4 o'clock in the afternoon, before I started one of my on-calls. And this is a pretty normal situation. 5 exploratory laparotomies and 1 below-knee amputation waiting. Mostly for trauma, 2 for a stabbed abdomen. The bowel evisceration was for a stabbed abdomen. The query appendicitis was generalized peritonitis, and it was appendix, and blunt abdominal trauma as well. And that's pretty normal. And considering most of the trauma comes during the night, this is just the starting point. So there's plenty to get on with. There's no one else. You're the most senior person there. You've got 1 intern with you as well. So that problem is all yours. And it's quite exciting, but a little bit daunting as well. The on-calls were about 30 hours long, so you'd work your normal shift in the day, the on-call start at 4 o'clock in the afternoon, you're on-call in the evening all night, and then you go home at about lunchtime the next day. There's about 5 of those a month. You don't look forward to them, but actually it's the whole reason you go away, I think. Supervision versus training. So this is quite a contentious issue. Everyone's got their own opinion on this sort of thing. There's not a lot of supervision. In the daytime, there's normally bosses around and you can get some good training. You tend to have your own theatres and your own operating lists, but you can always call someone if there's a particularly difficult case. At night time, the consultant, there's 2 of them there when I was there, I think there's 3 now, were on the end of a telephone, and it would always start with telephone advice. And there's a few times where I called a consultant 2 or 3 times during the operation, trying to explain to them what I can see, and him trying to tell me what to do. They don't come in an awful lot. They will always come in for a stab wound to the heart, a gunshot wound to the pancreas, or a major vascular injury. So you don't have to worry so much about those things. Living in rural for South Africa was absolutely fantastic. KwaZulu-Natal is a beautiful area, and I hardly saw any tourists there. Some of the South Africans go there on holiday, but it's a fantastic region. It's got some of the best game reserves I've ever been to. A couple of the top 10 dive sites in the world. And this photo I took from the Drakensberg Mountains in the background, which you can go just for the weekend just to do some walking. It's an amazing place to live, really. Other questions people always ask are how this is going to relate to their training when they come back to, whether it's England or Europe or wherever, really. You're taking time out of program, or you're postponing a training program to go and work in these sort of places. And I found, just anecdotally, that my consultants were all really interested to hear what you've done and what you've been up to out there, because you don't see any of this sort of thing, even in major trauma centres in the UK. So it's a fantastic thing to do, and I think they give you a bit of a longer leash when you come back. I think it's helped my training since I've been back in England, because you get to do more parts of more procedures, obviously under close supervision now, but it's just because you've had more experience and you can do more things. So I think it's benefited my training in that way. There was an awful lot of working autonomy out there, obviously. A lot of, all decisions really were made by yourself on call. And these are just little things like how to position the patient, where do you want the lights to be, what instruments to ask for, what do you want your assistant to do. Do you want the patient to go to intensive care after the operation or back to the ward? So there's a lot of working autonomy, a lot of theatre maturity, which I didn't expect to gain out there as well. You obviously come back with a lot of confidence. I feel I've dealt with most situations now. I don't feel that there's many situations I can be faced with in the UK which I haven't, where I haven't experienced something more significant or more disturbing. You have to be very adaptable, and I think you just learn this ad hoc, just as the situation arises. Whether it's triaging multiple traumas at the same time in casualty, then finding out your CT scanner's broken, and then you just decide clinically who to take to theatre. And then when you go to theatre, there's a power cut and all the lights go out. It's these sort of situations where you just, you give you a bit of an experience and allow you to think on your feet a bit. And they give you a lot of confidence coming back. And the other thing I wanted to mention was that we're all part of a global community now, and everybody in this room has got transferable skills. And I don't see any reason really why we can't use those skills in areas of the world which are badly lacking in health resources. Because it's a great benefit to us as trainees, but it's also a large benefit as well to the local communities that you're helping, because the issue is one of capacitance. There's just not enough doctors out there. All right, so just to sum up really. So the health divide between Europe and Sub-Saharan Africa is vast, and every doctor who works in these communities can really affect the delivery of healthcare there, and I really believe that. It's difficult to see how some of these hospitals in rural parts of South Africa can run actually without foreign qualified doctors. I know people wonder why foreign doctors go to rich countries like South Africa, but actually there's extremely poor areas where there's not enough doctors. And I have to say that if, talking just about the surgical department, for example, half of the surgical medical officers were British. So if you're not going to have foreign doctors there, you're going to have to close half your theatres, half your clinics, and who's going to do the ward rounds? So it is a short-term solution, but it's necessary at the time, and it does give you an opportunity to work with and train other local doctors as well, which is an incredibly rewarding thing to do. So it was an enormous challenge getting out to South Africa with all the paperwork, and when you're there, it's quite difficult on a daily basis, and I think every single day I was out of my depth. But the experiences you get and will challenge, I think, junior surgical trainees all the way up to experienced trauma consultants. There's enough work there of varying complexity that everybody's skills will be put to the test. And I said it was difficult getting to work. Well, this is a picture when I went down to the Transkei. There's been a little bit of rain overnight, and this is the state of the roads. So it really is difficult for some patients to get to hospital. And that really concludes my talk, so thank you very much.